Hi, I'm Hazel Zhang, and today we'll be presenting Shock Index Pediatric Adjusted Score versus Pediatric Trauma Score in the ED. So many scores, so little time. Different scoring tools have been established and validated to aid the prediction of pediatric trauma patients' outcomes and survivals, but not one is used consistently. Pediatric Trauma Score, or PTS, is one of the first tools ever developed and evaluates pediatric trauma rapidly in a comprehensive manner using 6 determinants to help predict outcomes. Shock Index Pediatric Adjusted, or SIPA, adapts shock index, which is heart rate divided by blood pressure, in predicting outcomes for trauma patients adjusted to pediatric population. It is unclear which scoring tool is superior or efficient in predicting outcomes at this current point. Our objective was to compare SIPA and PTS for level 1 and 2 pediatric traumas to determine if both are effective or if one is superior in predicting outcomes for pediatric trauma patients. This is a single-center retrospective electronic chart review study for patients 1 to 17 years of age with a level 1 or 2 activated trauma between January 2013 to November 2019. Patient visits were scored for both SIPA and PTS and applied to each visit separately, then placed into either high risk and low risk category as predefined by the individual scoring tools. High risk SIPA or elevated shock index for age, low risk SIPA or normal shock index for age, high risk PTS, which scores from -8 to 8, and low risk PTS, which scores more than 8. Our outcomes of interest was hospital admission, ICU and hospital length of stay, and complications of ventilator use, moderate to major liver or spleen laceration as determined by ICD code, blood product use, high index severity score, which is more than 15, and fluid bolus use. Our secondary analysis evaluated both scores together for each visit, creating 4 categories: PTS high, SIPA low, both high, both low, and PTS low and SIPA high. Of 1,442 patients, 750 met inclusion. The predominant scores for each tool were low risk. As you can see in Table 1 for demographics and scoring details, for SIPA, 588 were identified as low risk, 162 were identified as high risk. For PTS, 667 were low risk and 83 were high risk. Similar to previous literature, there were more males of 62% than females of 38%, and a peak at the adolescent age of 13 to 17 years of age. When the scoring systems were compared, 35 visits scored high in both systems, 543 scored low in both systems, and SIPA low PTS high was 48, and SIPA high PTS low was 124. If I can direct your attention to Figure 1, this shows the odds ratio for high-risk PTS and high-risk SIPA compared to their subsequent low-risk group. And as you can see, all outcomes had an increased odds ratio except for fluid bolus use and PTS. In Table 2, odds ratio for high-risk PTS was compared to high-risk SIPA, which showed outcomes such as admission, ICU admission, level 1 trauma activation, complications, and high ISS was more likely for PTS being high than it was for high SIPA. There was an odds ratio favorable to high-risk SIPA for fluid bolus. For our secondary outcomes, we compared the 4 groups against each other. As you can see in Table 3, we showed that if both scores were high, there was a higher likelihood of outcomes except fluid bolus use. When PTS high, SIPA low was compared to PTS low, SIPA high, there was a high odds ratio for all outcomes and complications, but a low odds ratio for fluid bolus. Figure 2 also shows an interesting aspect that for the both high-risk group was younger, and the median age being 3 years old. And for the both low-risk group, they were older, with the median age being 13 years of age. In conclusion, both PTS and SIPA tools are validated to predict outcomes for level 1 and 2 trauma in pediatric population. PTS does catch more high-risk visits, and the odds of complication and outcomes were much greater for high-risk PTS. PTS would be beneficial to use for critical patients to predict outcomes and complications, especially if they're being admitted or being evaluated with the surgical team. It's undetermined right now which score is more useful in the groups where the scores do not agree. SIPA is easier to calculate and will be more convenient to use in an acute setting. Given reliability of SIPA as an outcome predictor, this may be a fast and effective way to triage pediatric trauma patients in the ED and hospital setting. Thank you.